Hello, let's talk about restrictive lung disease. I have good news and bad news. The good news is that all of these pathologies have the exact same physiology going on underneath them. So if you understand the basic physiology, the fundamentals, because that's high yield concepts, you're going to get 2 or 3 questions right. The bad news is that this SDL has a whole ton of details on it. So get your highlighters out, and if you have time, give this a second pass and really try to absorb some of the information. Don't focus on memorizing things. Just read it and trust your brain to present the facts to you and to connect the dots whenever you're faced with a test question. Let's talk about the physiology of restrictive lung diseases. The overarching thing in restrictive disease is that it's an inhalation defect. It's really tough to move air into the lungs. And the reason why it's tough to move air into the lungs is because the lungs are going to be a higher pressure at rest. And the lungs are going to have a higher resting pressure because they're fibrotic and they're scarred up with collagen because of just generalized inflammation. A lot of different ways to get inflammation, hence all the different pathologies in this text. But then once the inflammation ball gets rolling, the lungs scar up and you lose elasticity, you gain elasticity, you lose compliance. And what those 2 variables mean, if you lose compliance and gain elasticity, well, then your lungs are going to want to collapse inwards. And so that generates higher pressures in the lungs. And because air follows pressure, low pressure, if the lungs are higher pressure, air is less likely to move into the lungs, and it takes more work to move air into the lungs. So that explains the lower resting volumes. All of the volumes across the board are lower in restrictive lung disease. And if you order spirometry, you see that your forced expiratory volume in 1 second is going to go down, and your forced vital capacity is also going to go down, but the ratio of these 2 parameters is going to stay the same or go up. And so that's your differential between an obstructive and a restrictive lung disease. Remember, spirometry is typically going to be one of the very first tests you order, especially in a primary care setting of patients complaining of shortness of breath, dyspnea. And the lower total volumes in the lungs, as exemplified by the balance on this compliance curve here, leads to a ventilation defect because when you think of the VQ ratio, Q is not changing. The amount of blood perfusing the lungs is not going to change, but if your volumes are down, your ventilation is going to drop over time. And when you break apart the compliance curve for restrictive lung diseases, you see that the restrictive disease, which is the dotted red line here, has a lower slope than normal lungs as represented by the continuous red line. And the compliance of your chest wall here is represented in green. And remember that your lungs press against your chest wall and they have a resting balance between them. There is a pressure homeostasis between your lungs and your chest wall because your chest wall wants to move out and your lungs want to collapse in inherently. They're tissue properties. And so in order to balance pressure between the chest wall and the lungs, well, the pressure has to be at a point that's equilibrated between the compliance of both entities. And the graphic representation of the words I just said is the dot representing the pressure in the lungs has to be equidistant from the compliance curves of the walls of the chest and the lungs. So if you decrease the slope of the compliance curve for the lungs, then to keep the same pressure, and you will keep the same pressure because you keep homeostasis between these 2 opposing forces, you're going to have a decreased lung volume in order to do so. So the dot moves down the y-axis. That's an overview of all restrictive lung diseases. Again, remember, why is the compliance in the lungs decreased? Fibrosis and scarring. Why is there fibrosis and scarring? Well, let's find out. Again, all of these are characterized by decreased lung volumes across the board. Not one single lung volume goes up in a restrictive disease. This leads to a VQ mismatch specifically because V drops ventilation, airflow. And so you're going to get hypoxemic, and then you're probably going to get a compensatory tachypnea to try to get oxygen in. And this increased breathing rate is going to result in you losing CO2 to the atmosphere, right? And so the CO2 content in your blood's probably going to initially drop upon acute exacerbation, and that's going to lead to what we call a respiratory alkalosis, because remember that CO2 goes through the bicarb equation and pops out a proton on the other side thanks to carbonic anhydrase. So when CO2 in the blood goes down, protons in the blood go down. So when you get tachypnea, can you speed up your breathing rate to attempt to get some oxygen into your blood? You blow off more and more and more CO2. So that's less and less and less in the blood and less protons. And so that's the basis for respiratory alkalosis. And then what you're going to see is a metabolic compensation, which typically looks like more bicarb produced by the kidneys. So there are intrinsic and extrinsic restrictive lung diseases. We're talking about the intrinsic restrictive diseases, which are lung diseases, not chest wall, pleura, or respiratory muscle diseases. Again, all interstitial lung diseases have this in common. There's something that generates widespread inflammation. And the inflammation goes up, and you get your M1 macrophages with your TNF alpha, and then it goes back down. And when it goes down, it's because you have these M2 macrophages that realize, okay, inflammation's over, everybody go home, time to scar. And the molecule associated with that is TGF-B, TGF-beta, transforming growth factor beta. So what TGF-beta does is it tells fibroblasts, throw down some collagen because there's been tissue damage in this area. And the fibroblasts do that, and over time, the accumulation of collagen, well, that anchors things together. And so when you anchor tissues and cells together inside your lung parenchyma, well, that's a greater elasticity because the lungs want to shrink anyways. So if you add connections in between components of the lungs, it just wants to shrink even more. So that's your loss of compliance and gain of elasticity. That's going to lead to that down tilt of the slope on the compliance curve. It's going to create higher pressures in the lungs. And remember, air wants to move to where there's low pressure. So there's going to be decreased total volumes in the lungs. Now, interstitial lung diseases, that's the name that we give to things that can cause diffuse scarring in the interstitium of the lungs, the interstitial space obviously being in between cells. And there are a lot of ways to get this. It can be idiopathic, and we've even got some subsets within idiopathic. It can be very often due to pneumoconiosis, which is typically an inhalation of dust, and then it can be to a hypersensitivity pneumoconiosis as well. That's going to be when you inhale something that causes your body to have a reaction against its own cells, such as maybe certain fungi can do that. And then we have interstitial lung disease, secondary to larger systemic autoimmune diseases such as lupus and RA, rheumatoid arthritis, and systemic sclerosis. We have interstitial lung disease associated with drug exposure, a lot of chemotherapeutics, and even a couple of antibiotics. And then sarcoidosis is kind of often a category of its own. We don't have a very good definition of sarcoidosis yet pathologically, but we know exactly what it looks like. And then there's pulmonary alveolar proteinosis, which is its own category as well, because that's going to be a surfactant overproduction, and the lungs are going to get very, very wet and boggy. And so it'll lead to an interstitial disease. It leads to interstitial scarring very indirectly. Let's talk about the pathophys. And remember, we said FEV1 to FVC ratio remains normal. So what is that measuring? Well, your forced expiratory volume in 1 second is how much air can you breathe out in 1 second. And so that's decreased, right? But then your forced vital capacity is also decreased. because your total lung volume is decreased. So that's why the ratio stays the same or goes up. Now let's contrast that to obstructive lung disease. In obstructive lung disease, you have a problem getting air out of your lungs. So you've got an increased total lung volume. So your forced vital capacity actually goes up because you can breathe out more total air. But because you have a difficulty initiating that process, your FEV1, the first second of breathing out, is going to go down, way down. And so the FEV1 FVC in an obstructive diseased patient looks like 0.6, looks like 0.5, versus a restrictive disease. You don't have a problem getting air out of your lungs. You don't have a lot of air in your lungs, but you sure don't have a problem getting it out because it wants to go out. Why? Because it's a higher pressure in your lungs. Why? Because they're more elastic. Why? Because there's fibrotic scarring. So the ratio is normal or elevated. That's your number one step in differentiating restrictive disease from a host of other pathologies. Let's talk about idiopathic interstitial pneumonia. Anytime you see pneumonia, we're really thinking fluid in the alveoli, and that can be due to a lot of different causes. Traditionally, we think bacterial pneumonia, or viral pneumonia, infective pneumonia, but idiopathic pneumonia is for when we can't put a pin on the cause. So remember that we've got low compliance, higher elasticity, because this is a restrictive disease. We've got a lower FEV1 to FVC, or a higher FEV1 to FVC ratio, because there's no problem getting air out of the lungs. Idiopathic pulmonary fibrosis is a progressive interstitial lung disease characterized by fibrosis of the pulmonary interstitium of unknown etiology. So that's pretty good news because you don't have to know what's going wrong here. You just have to predict the consequences. And we've gone over it a couple times already. It's kind of easy to predict. You get this decreased compliance, which means there are lower total lung volumes, which means you get hypoxemic because of a ventilation defect. And the hypoxemia can just snowball over time. And then if you don't have enough oxygen, all the cells of your body are going to suffer as a result. But it's going to be your lungs that typically fail first because that's the point of injury. And then your heart is going to be very shortly thereafter. And it's going to be a right heart failure because this is typically going to lead to a pulmonary hypertension due to all of the scarring around arterioles. And the pulmonary hypertension generates a right heart volume overload, and that can lead to cor pulmonale, and we know what right heart failure looks like. So idiopathic pulmonary fibrosis, most common cause of idiopathic interstitial pneumonias. Most cases are sporadic. There are a couple of genes that we have identified. I don't think that that's high yield, but know the gene, just be able to recognize the genes and pick them out of a crowd. There's telomerase genes, and then there's MUC5B, mucin 5B. So your lungs actually do have a pretty good divisive capacity, right? Remember that certain cells, such as neurons, they don't divide at all, right? But because your lungs have a moderate ability to replace themselves, then a telomerase gene mutation would affect the lungs fairly heavily. And that's your type 2 alveolar pneumocytes that are going to be responsible for replacing type 1 pneumocytes when they're damaged. Again, we don't know how you get it. Of course, there's a million different risk factors for it, but that's not what we care about in terms of an exam question, because this is idiopathic, so the question is probably going to be predicting the consequences again. So another way to say it is that we have persisting injury and aberrant wound repair with unremitting fibrotic response. And what that means is you get inflammation, and then you get the TGF beta to heal it. Then you just keep getting inflammation again, then it heals, and you get it again and it heals. Failure of fibroblast apoptosis leads to myofibroblast accumulation. So that's going back to telomerase. If these fibroblasts are sticking around for too long, well, then you get a lot of fiber. Again, TGF beta is very important. It induces fibrosis. And how do we get TGF beta into macrophages? And what cells does TGF beta act on? Fibroblasts. So your lung transforms to this beautiful picture here on the right, which is just A lot of spindle cells in there, a lot of space in between cells indicating collagen deposition and scarring. And then you can totally see where the lung ought to be, right? Like you see this kind of cul-de-sac alveolar type structure, and you're seeing a lot of space here where there ought to be normal alveoli, normal type 1 pneumocytes, but there's just an extremely dense amount of scar tissue up in the interstitium of those lungs. So we call this histopathologic pattern usual interstitial pneumonia, which, I mean, I guess it's on us, you know, the next generation and the next wave of practitioners to come up with a better definition of it. I mean, I got to give props to the people who have gotten us this far, but usual interstitial pneumonia kind of makes you laugh because it doesn't really tell you anything at all. It's characterized by fibrotic lesions at different stages. So what's that kind of like? Kind of reminds you of multiple sclerosis, right? Where you've got different attacks at different times, and then the presence of 2 attacks at different locations at different times is the diagnostic criteria for MS. Well, same thing here. The fibrotic lesions at different places at different times in their evolution is what characterizes usual interstitial pneumonia. You're going to see a lot of different cell types in there. Right here at the top of page 5 is your histology of it. And it's important to note grossly that you're going to see honeycomb changes, which occur at the bronchiolar hierarchical level of lung organization. Remember that it's important to understand where you are at the lungs when you're referring to a particular pathological change, grossly or histologically, right? And so you start with your trachea, and then you branch into 2 primary bronchi, then you branch into secondary bronchi, then you branch into tertiary bronchi, and then you branch into bronchioles, and then you branch into terminal bronchioles, and then you branch into alveolar ducts, and then you branch into alveolar sacs. And so honeycomb cysts occur at the level of the bronchioles, which are going to be your small terminal airways. Now, the big picture of the lungs at the end of idiopathic pulmonary fibrosis, they're going to be cobblestoned, which means there's going to be a lot of cirrhotic scarring, and the remaining functional areas of the lungs are going to hypertrophy in order to kind of pick up this slack and compensate for the fact that you've got a lot of dead lung tissue. So where have we seen this before? Cobblestone kidneys in the setting of hypertension, right? You start knocking off glomeruli, and the remaining glomeruli swell and hypertrophy to compensate for the greater flow that they're seeing because some glomeruli are dead. Honeycomb lung is a non-specific finding, but it at least gives you a clue for what's going on. When you see it, again, you're thinking it's something kind of general. And you're going to also understand that it's a restrictive pathology too, right? So that's going to maybe alter your treatment a little bit. Hell, I don't know. There is a considerable latency period that may last 1 decade or more. So this is a slow presentation, similar again to obstructive disease, chronic disease. Patients report insidious onset exertional dyspnea, means they have trouble breathing. It's going to lead to a hypoxemia that just gets slowly and progressively worse, and so they're really not going to present in a question stem until they fall off the cliff proverbially, right? And they start going into pulmonary hypertension. You see crackles, rails in the lower lung zones. Sounds like Velcro. You see digital clubbing in some patients. The digital clubbing in the setting of restrictive lung disease is secondary to hypoxemia, which induces the digital endothelial cells down in your fingers to start producing things like VEGF, right? Which is produced in response to hypoxia everywhere. And so VEGF is going to get capillaries proliferating, which is going to stimulate tissue growth. And I want you to recall that clubbing is also seen in response to certain cancers that secrete certain molecules into the bloodstream. And when they do secrete bioactive hormones into the bloodstream, we call that a paraneoplastic syndrome. And there are some specific pulmonary cancers that can give you a paraneoplastic symptom of clubbing due to the release of growth hormone or hepatocyte growth factor into the bloodstream. So when it gets down and pools in your digital arteries, blood flows very slow there, so they're prone to hormonal response. Then the beds of tissue in your fingertips and toe tips are just going to swell and club up. Then end-stage disease again. Where are we going with this VQ defect, this drop in ventilation, hypoxemia into pulmonary hypertension, into cor pulmonale? And the hypertension's also going to be secondary to the concept of hypoxemic pulmonary vasoconstriction, right? So if you add that up, right, and that gets bad enough, well, then you're trying to maintain the same cardiac output. So you're putting more blood through the arteries that you do have left open, and then that volume will just back up over time. Spirometry findings, again, this is a restrictive disease, this idiopathic disease, so all your volumes are down as opposed to an obstructive disease in which certain volumes, specifically total lung capacities and expiratory reserve volumes, those would be up in an obstructive disease. And again, lab findings, if you look at blood work, then these patients are going to have an alkalosis at rest, right? Because they're hypoxemic, and so they're typically, their respiratory rate's going to be 22, 24, might be 26, right? Because they're trying to get oxygen into their body, and so the result of that tachypnea is going to be they're blowing off carbon dioxide, and so they're going to have low protons in their blood. That's your alkalosis. And respiratory acidosis, where does this come into the equation? Well, I'll tell you, there's a couple times you'll see respiratory acidosis in the setting of a chronic disease. And that's going to be whenever you have a literal obstruction, not just obstructive lung disease, but specifically like in the setting of chronic bronchitis, mucus plugs. Okay, well, then you can get an acidosis because you're trying to get CO2 out of your body. But because there's an obstruction, you can't. So maybe it looks like you swallowed a peanut and it got into a secondary bronchiole in your right middle lobe or right upper lobe, right? Well, then everything downstream of that literal physical obstruction of the airway can't get CO2 out. So your body's going to hold on to CO2, and that's what's going to give you a long-term or chronic respiratory acidosis. But besides that, besides a blockage of an airway that prevents CO2 from leaving, you're not going to see a respiratory acidosis. It's usually going to be alkalosis in response to the hypoxemia. You raise your breathing rate and that blows off CO2. And then another setting you can see acidosis in is going to be very acute respiratory failure. Because in that setting, you're just not breathing. Your lung volumes are so far down that you're holding on to CO2. Your airways maybe are open, right? But you just can't move CO2 out because you're in respiratory failure. So that's an acidosis as well. Anytime you're not breathing, respiratory acidosis. Anytime you're breathing too much, respiratory alkalosis. Back to the lung volumes, FEV1 to FVC ratio is going to be normal in a restrictive disease. Why? Because both are down. So why would the ratio be lower in an obstructive disease? Because FEV1 is down and FVC is up, up, or not down as much, rather. You see hypoxemia, you see the alkalosis due to the increased CO2. And it's a reflex tachypnea that is mediated by cranial nerves 9 and 10, sending signals to your medulla oblongata, your dorsal respiratory group, right? And then that's going to speed up your breathing rate. Let's talk about imaging. And you see reticular markings in this idiopathic pulmonary fibrosis. And what that means is you see straight lines, okay? And so that means you see fibrosis around the conducting tubules and not really around the alveoli themselves. And you're going to see, well, let's look at what it says. You see reticular markings predominantly at the periphery and the bases. So what does that mean? Well, which airways are at the periphery of your lungs? Your terminary bronchioles, okay? So it's not like your primary bronchi. No, that would be like at the hilum of your lungs, okay? So because it says and shows you in some cases the opacities at the periphery, well, that's how you know which airways are affected. And again, it's going to be fibrosis. The reticular markings around the periphery tells you it's fibrosis around bronchioles. You might see subpleural honeycombing, cystic air spaces. And if there's air inside a sphere, it's going to be radiolucent. It's going to be black on X-ray. And then if there's fluid inside that sphere, it's going to be opaque. It's going to be light on X-ray. And that's going to be called your ground glass change. Anytime there's spheres of black and white inside the lungs, and that's a diffuse and non-specific change. So we treat idiopathic pulmonary fibrosis with lung transplant. And that's the disease. Here's a quick differential. We've got non-specific interstitial pneumonia, which occurs in patients with an autoimmune disease. So females have a predominance there. And you can see it in drug-induced interstitial lung disease. Remember, we said that chemotherapeutics are your most common route for that. And then also with hypersensitivity pneumonitis. We're going to talk a little bit about that later on, I believe. Pulmonary function tests show a respiratory or show a restrictive defect. And again, for all of these, you're going to see some sort of restrictive spirometry because that is your differential. Well, what could cause a restrictive spirometry? These three things, okay? Respiratory bronchiolitis interstitial lung disease occurs exclusively in current or former heavy smokers, and biopsies reveal pigmented macrophages. It's typically going to be carbon with the lumens of respiratory bronchioles. Within the lumens of bronchioles, yeah. So again, that's telling you you're going to see reticular patterned imaging along the periphery of the lungs. Lymphocytic infiltrates on histology, yeah, okay. And then cryptogenic organizing pneumonia, you're going to see a lot of granulation tissue in this. And please remember, granulation tissue involves scarring plus a lot of capillaries, a whole lot of capillaries, because what is granulation tissue? Well, whenever you fall down and get a scrape, you get a boo-boo, right? Well, it gets a scab over it. And I know that at least once in your life, you just peeled that scab off just to see what would happen, right? And it's all pink underneath the scab, and it might still be a little bit sticky, and that's granulation tissue. So I don't really see a question coming from the differential diagnosis section of this. Again, there's a reason why there's only one paragraph on these things. And there's just too much else to ask in this SDL. Let's talk about pneumoconiosis. A lot of different methods, pathways through which you can get pneumoconiosis, the diagnosis. It's got a characteristic progression. You inhale some particulate matter. Your lungs react to this by throwing down a lot of scarring tissue. And that makes an oxygen diffusion defect. Oxygen doesn't like to diffuse through all that collagen, right? That's like a traffic jam on your way to work, right? You like it when you can drive to school in 10 minutes. You hate it when you hit every light and then there's a train and then there's this dude who is in the right lane at a red light and he's not turning right. He's going straight, but he's in the right lane. And so you're trying to turn right and you're just waiting behind this car for a minute and a half because you're just like, man, you should have gone to the left lane, buddy. But that's the oxygen diffusion defect. Oxygen doesn't want to move through scar tissue. And this leads to a VQ mismatch. Your ventilation goes down. You get hypoxemic, and then this can onto pulmonary hypertension, okay? And again, because this is a restrictive defect, it's characterized by low compliance, high elasticity, which is going to contribute to the higher resting pressures, which is the higher resting pressure is the reason why air does not want to move into the lungs. And air not moving into the lungs is the reason why FEV1 to FVC is going to be higher. Pneumoconiosis is a term for a class of diseases caused by the inhalation of mineral dust. Check. Well, there's a lot of mineral dusts. And I know it really seems like, you know, kind of unfair, actually. Just, it's so Jeopardy to be testing us about just random facts about silica, right? But that's what they do. So that's what we're going to have to get used to. And these dusts are going to look differently inside the lung at a very microscopic level. And then some of them are going to cause a lot more irritation than others. Let's start with coal workers' pneumoconiosis. Obviously, coal mining used to be a massive industry, and so this diagnosis was extremely prevalent back in the 70s, 80s, 90s when America was largely powered by coal. It still kind of is in some regions, especially amongst the Southeast, West Virginia, Kentucky, those sorts of states. So coal dust is really a lot of carbon, and that can lead to anthracosis, and that anthra is going to mean black pigmentation, right? Like anthrax. And that's because anthrax causes black eschars, ischemic necrosis, just in case you were wondering. That's why it's called anthrax. So coal dust leads to anthracosis. The lungs are going to be black. And there's the dust inhalation part of it. So you can be very asymptomatic for a long time, and then you're going to get this progressive massive fibrosis, and it's going to be a slow progression, but it is going to involve the whole lung if it's a lot of dust inhaled over the years. Here's what it looks like pathologically. Here's a zoomed in view. Again, you can tell that there's dust. Where's the pigment? In the interstitium of this lung on the right, okay? So it's in between alveoli. And here you can tell it's a diffuse disease. You slice the lung open and yeah, it's just everywhere. So the dust gets into the lungs, and then where does it go? Well, the answer to that is that your macrophages want to eat it up because they're your trash compactors. They're your brooms. They're going to chew things. So the dust gets into macrophages, and the macrophages can't do anything with it because it's like, what are you going to do? Kill it with oxygen radicals? Ha, it's carbon. Try it again. And then the macrophages, if they reach a critical overload of carbon inside them, they're going to go to the lymphatics, and they're just going to chill there. And so maybe you can get a lymph node biopsy, and it's just going to be pure black on the inside because it's all these carbon-containing macrophages. So you've got simple coal lung and then complicated coal lung. In simple coal lung, you don't get any symptoms at all. You have no clue you have it. But if you did a biopsy, you would see some very small nodular lesions with a preference for the upper lobes. Complicated coal lung, complicated coal workers' pneumoconiosis does show a progressive fibrosis. Takes decades to develop, but if you cut the lung open, you're going to see black scars larger than 2 centimeters. They're typically nodular, but then they can be reticular. They can be streak-like as well, and they can travel along lymph channels, right? Because it's the carbon's inside macrophages. And as the coal gets into the lungs and the macrophages are scooping it up, well, the macrophages are activating in response to all this carbon dust, and then they're deactivating. And when they deactivate, you get the TGF-beta leading to fibrosis. So that causes your oxygen diffusion defect, leading to symptoms of exertional dyspnea. Patients might have a melanoptosis with black sputum. And then over time, the dyspnea leads to hypoxemia, which is going to, the end of the line for that is respiratory failure, and that's as your V approaches 0, okay? Because it's a VQ defect when that oxygen starts to drop. So overall, for that coal worker's lung, patients are fine until they get into the 3rd or 4th decade of progression, and then they start to really be at risk for some quick downhill exacerbations. Let's discuss silicosis. So silicosis, same thing. You're going to get dust, you're going to get fibrosis, and you're going to get an oxygen diffusion deficit leading to a low VQ. So silicosis has, again, all the symptoms of restrictive lung disease, so lower total volumes and a lower FEV1 to FVC ratio, or a higher ratio, my bad. I keep mixing that up. You know, you don't get it right on the test. You see nodular imaging in silicosis as opposed to reticular imaging. And again, those are the 2 classes of X-ray and CT lesions we see in the lungs. It's either nodular, reticular, linear, or a combination of both. And in silicosis, the histology are these big pink spheres and whorls and nodes, and kind of looks like a keratin pearl, except there's no cells in it. It's pretty acellular. And It's silicon dioxide, which is a crystalline substance, so it arranges on itself in a shapely manner. The people who get silicosis are those who work with sandblasters. So people in the early stages of construction when you're setting the foundation for a building, and then people who work with sandblasters. I think I just said that exact sentence. Glass makers, stone cutters, and ceramic workers. So please pay attention to who can get all of these different diseases, because examiners love to ask that. And they love to make the diagnosis dependent upon your ability to infer it from the exposure. So coal miners are also at risk for silicosis as well. And then they can have pneumoconiosis at the same time. Lucky for you, again, these things present the exact same way. Silicosis usually presents after decades, again, after decades, very chronic, as a nodular fibrosing pneumoconiosis. So you know by the fact that it's nodular that it likes to ball up and then also get into the lymph nodes. Silica particles interact with aqueous media to generate oxygen radicals. And that's because these things typically have a very cationic valence, right? So they're going to be charged with a positive charge, meaning that, sure, they can accept an electron, and then water floating around is a possible electron donor, and that can generate a hydroxyl radical. And then you're going to have to deplete your glutathione peroxidase, or you're going to have to use your superoxide dismutase in order to neutralize those hydroxyl radicals. And if you don't have enough enzymes to do that, or if there's too many radicals, then you're going to get some pneumocyte injury and macrophage injury. And then this injury generates inflammation, and then it'll run its course. And when it goes downhill, you get the M2 activation with the TGF beta, and that leads to fibrosis. So that's your scarring in the setting of silica dust overload. You can get an acute silicosis, and that's like, that's if somebody said, hey man, like, you want to try this, snort this dust, you know, it's, oh, joke's on you, it's silica dust. So if you just take silica dust to the face, I don't know, maybe you're not wearing your personal protective mask or whatever when you're jackhammering, and that could lead to an acute silicosis. Otherwise, it's going to be chronic silicosis, and it's going to take a while to present. Of note here in this paragraph is the alveoli are filled with a granular eosinophilic material that is PAS positive and diastase resistant. So it's dry, but remember it because it will sure help you differentiate from other dust conditions. And also for silicosis, the fact that it's eosinophilic is really cool because every other pneumoconiosis tends to be pretty darkly pigmented. Chronic silicosis is going to develop over decades rather than weeks or months. Once more, you see these silica particles surrounded by fibrosis with a lot of immune cells nearby and fibroblasts too, so that's not telling you anything you don't know. Silica particles are birefringent. What else is positively birefringent? Do you know? Pseudogout. What shape are those crystals? Rhomboid. What color? Blue. So silicosis can lead to progressive massive fibrosis, which is just going to be the oxygen diffusion defect leading to a VQ mismatch. Acute silicosis goes downhill quick. Chronic goes downhill over a long time. Isn't telling you anything too complicated here. It's a restrictive disease, so you know what spirometry to expect. Low, all lung volumes are low. And then here we encounter, for the second time in this SVL actually, this concept of mixed restrictive and obstructive disease with a reduced vital capacity, so decreased total lung volumes and a decreased FEV1 FVC. So what you would see in an obstructive pattern is increased FVC with the decreased FEV1, FVC. And then what you'd see in restrictive is decreased FVC with increased FEV1, FVC, okay? So in obstructive, they're opposite. In restrictive, they're opposite. But in a mixed disease, they're both down. Imaging, silicosis appears as typically a nodular pattern, not a reticular pattern. And you can see hilar or mediastinal lymph nodes calcify. And again, if a lymph node calcifies or has a lot of silicone in it or something, then that's a node, right? So that's contributing to your nodular pattern, and that's got a fairly wide differential, but you got to take a good patient history. And if you do, then, oh, well, yeah, I used to work in construction, or I used to lay a lot of drywall, right? That'll come up, and then you'll be like, I see what we're dealing with now. Complications, cyanosis, cor pulmonale, respiratory failure. Big deal here, yo. Very big deal. Subjects exposed to cilia have shown a much higher incidence of TB than in comparable unexposed groups. So you've got a very high risk of a tuberculosis complication here. We haven't seen that with much other diseases at all. You know, usually it's cancer. And that's a real great way to just get you on the hook. Like, oh, I got you. Like, what's the most likely complication? I'll say cancer, say cancer, say cancer. And you say cancer, and they're just like, they are out here fishing, yo. So it's tuberculosis if it is a silicosis. So check the employment history and see what this person did for a living. Let's talk about asbestos. And see, that's why I say they're fishing, because if they say, all right, this patient has asbestosis, what's the complication? And the answer is cancer, yo. And it's going to be a malignant mesothelioma if they have a history of these pleural fibrosis, these pleural calcifications, right? And then asbestos can also just cause a normal primary lung carcinoma. So for asbestos, the answer is cancer. What are the occupations related to asbestos? Mining, manufacturing, building, particularly building houses, because asbestos was in a lot of roofing material and insulatory materials and ceiling materials. And so people who built houses or large buildings in kind of the 60s to 90s period can be at a higher risk for this. And then people who worked in shipyards as well. So that's your dust exposure, right? And all of these pneumoconioses, they start off with, you inhale a lot of dust of something. So what's particular about asbestos compared to the other pneumoconioses? Well, you see reticular imaging. You tend to see reticular, not nodular imaging. And if you zoom in on a tissue, you see these segmented linear deposits of dust. And they're often going to be dumbbell shaped. And that's going to be in contrast to the big clumps or globes of silica deposit. You're going to see a pleural fibrosis, and that's pretty particular to asbestos too. Where's the pleura? In between the lung and the chest wall. Does silicosis affect the pleura? No. Does coal lung affect the pleura? No. Does asbestos affect the pleura? Yes. And then asbestos diseases have really, really ugly complications. And I mean, not ugly in the sense that they'll just kill you out of the blue when you're 40, but ugly in the sense that you wouldn't want anybody to live with some of the diseases that come along with asbestos. They're very painful. Asbestosis is kind of the primary disease of asbestos inhalation. And here's the histology. You see a bunch of, again, they look like barbells, you know, you're doing curls or something, and you got like 45s on each side. They look like that. And they're going to be colored golden brown with multiple segmentations, and that's the real characteristic way to talk about asbestos bodies, because they don't always have the dumbbell shape. And they're sometimes referred to as ferruginous bodies, which means they have iron in them. Think ferric and ferrous. Those are the two forms of iron inside our body. And asbestos does tend to complex with iron. And because it complexes with iron, It can lead to an iron overload in the interstitium of the lungs, and we'll talk about that in just a second. So you inhale a lot of asbestos dust, you get pulmonary fibrosis, TGF-beta, all that good stuff. Chest radiograph shows a fine reticular pattern of lighting up an X-ray or CT. Then you can get these pleural plaques. Here we go. This is big time characteristic of asbestos. And oh, this sounds so wrong. It looks like peanut brittle, you know, or it looks like looks like the cookie part of like a vanilla Oreo. So that's a pleural plaque, and it's going to be in between your lung and your chest wall. And this can happen in someone with no history of asbestos exposure, but asbestos sure does predispose you to it. And then finally, primary lung cancers and mesothelioma. Your mesothelioma risk is 1,000 times higher if you do have a positive asbestos exposure. And if the patient has the history of a pleural plaque, then they're probably going to get mesothelioma at some point. So why does asbestos cause problems? Well, we know it's a particulate dust, so the macrophages probably have a tough time, you know, chewing it up and processing it. So they probably get overloaded, and then that generates some inflammation, which spills over to other cells. And that's exactly what this thing says. The fibers themselves are toxic to epithelial cells plus macrophages. And so not only do you get macrophages popped open, you get pneumocytes that just off themselves because of all the asbestos within them. This leads to a widespread fibrosis, which can be hastened by the formation of free radicals from the iron that complexes with asbestos, because iron's not good, because iron can pick up a electron from hydrogen peroxide through the Fenton reaction, and it'll go to Fe3 plus, right? I think that's ferric iron when it does that. I always get ferric and ferrous mixed up. But it goes to Fe3 plus, and then it leaves an OH radical. And that's not good, because you got to send that OH radical through a radical quenching system to do that. And in order to do that, you need a lot of NADPH. And in order to create NADPH, right, you've got to be throwing your pentose phosphate pathway into high gear, or you've got to be synthesizing fatty acids. So you need energy in order to do that. And if you don't have a lot of energy, you're not going to be quenching a lot of free radicals. So that's the stepwise process of iron making radicals, and that's very bad for cells at the end of the day. How does asbestosis present? Well, it's a pneumoconiosis. So the patient gets a very slowly progressive fibrotic dyspnea due to the diffusion defect. Oxygen doesn't want to go through collagen. You get a VQ mismatch. Specifically, the ventilation goes down. You get hypertension of the lungs. As a result, you get some cor pulmonale that can go down into heart failure. That's all of our pneumoconioses. Again, those are inhaled dust diseases. Section called granulomatous diseases. Remember, these are restrictive lung diseases associated with low compliance and high elasticity, which generates higher pressures, which makes it tough to get volume in. So the lungs are at a lower resting volume. So your FEV1 is going to go, it's going to be down, but it's not going to be too far down, because you don't have any problem getting air out of the lungs. And your FVC is going to go down too. So the ratio is going to stay the same or go up. So it's a restrictive pathology. Let's talk about sarcoidosis. Not the easiest thing to understand, but the big takeaways are that you get granulomas, and granulomas aren't nice to other cells. Granulomas make other cells throw down collagen just to get away from the granuloma, right? And so you get some granulomas, and then you'll get a widespread fibrosis in the lungs. Now, these are non-caseating granulomas, and what that means is it's not tuberculosis, which is important, because which organ do you get TB in? Your lungs. So anytime you see granulomas in the lungs, you got to know why they're there. Now, a non-caseating granuloma is a type 4 hypersensitivity. It involves macrophages, which can fuse with one another and form giant cells. And then there's also going to be a lot of CD4 plus helper T cells involved as well, propagating the interferon gamma that gets macrophages shifted into epithelioid mode, okay? So typically, a granuloma is going to be related to an autoimmunity, right? Because it's a hypersensitivity. So there's a specific antigen that bugs out some T cells and they pull macrophages into it, right? And then the macrophages just, oh, they go giant cell. So we think that Mycobacterium has a role in causing sarcoidosis, okay? So that's your TB. TB, remember, picks up Lowenstein-Jensen stain. It's an obligate aerobe. It's got sulfatides. That's its go-to virulence factor. It's got cord factor, which helps create granulomas. And it's got a mycotic acid membrane, okay? And so maybe the mycotic acid is going to be one of the specific things that get your immune system acting against your own body. And then mycoplasma, we think, may have a role in causing a sarcoidosis. And mycoplasma is a bacteria that has cholesterol in its cell membrane. You ought to be thinking mycoplasma when there's cases of atypical pneumonia. Okay, so somebody young and maybe has history of exposure to a locker room setting or military barracks. These are people who shouldn't get pneumonia and who present with bad pneumonia, but without the typical, oh, I feel like crap of pneumonia. Okay, so that's walking pneumonia. That's mycoplasma, and it's also associated with cold agglutinins, which are going to be proteins that crystallize and turn from kind of fluids into solids at low temperatures, and that damages your bloodstream, gives you a sort of a vasculitis, and so those cold agglutinins might play a role in the autoimmunity. Then there's chlamydia. What do we know about chlamydia? Well, it's got a reticular body and an elementary body, and it's going to be intracellular inside macrophages. And chlamydia also has, muramic acid inside of its cell wall. So it's got a weird cell wall component, right? So what these things all have in common, plus fungi, plus viruses, they have cell wall constituents that you don't see on a regular basis. And so your immune system sees these shapes and it goes, oh, we need antibodies against that. And then the problem is going to be that the antibodies that they make against these shapes is going to also fit onto a certain protein elsewhere in the body, and that's where the autoimmunity arises from. So these are non-caseating granulomas, type 4 hypersensitivity. Histologically, you see epithelioid cells, meaning they look like epithelial cells, but they're not. They're macrophages. And they're going to have giant cells. You don't usually see necrosis because the cells are very healthy, trust me. They're just big, massive. And you see a lot of scarring around. And anytime you see hyaline scarring, it's going to be pink and eosinophilic on histology. And the scarring leads to an oxygen diffusing defect, which leads to a low VQ ratio, which leads to your hypoxemia and your pulmonary hypertension, right? Histologically, the lesions are distributed primarily around the lymphatics, around bronchi and blood vessels. All their alveolar lesions are also seen. Well, that's helpful. So here's what it looks like. Notice that if this were TB, you would see caseating necrosis in the middle of almost every single one of these granulomas. Like right there in the core of it, you would not see very many nuclei whatsoever. But because the middles of these granulomas have cells in them, they're cellular, so you know it's a non-caseating granuloma. So then you see like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 of them right there in one slide. And you say, man, what could cause so many granulomas in one place? And sarcoidosis ought to be very high up on your list. The imaging hallmark of sarcoidosis is going to be big old lymph nodes, and even the tonsils can be involved, and even the eyes and the muscles can be involved too. You can get these granulomas in multiple tissues besides just the lungs. The presentation, however, is typically going to begin with dyspnea due to the lung involvement being the first to present, really. And then constitutional symptoms are actually, I know we say those are non-specific symptoms, but almost everyone with sarcoidosis has this malaise that is pervasive and will not go away. And that's often why they go to the doctor for the first time. So I know we say non-specific, but for sarcoidosis, it's actually pretty specific. If you look at their blood, you could see high angiotensin converting enzyme, and you could see hypercalcemia due to vitamin D precursor. Well, not precursor, that is active vitamin D, because remember, vitamin D is made in the skin, and then you send it to the liver, and then it gets hydroxylated, and it becomes that 1-hydroxy vitamin D, or I'm sorry, the 25-hydroxy vitamin D. Then you send it to the kidneys, and it gets hydroxylated again to 1,25-dihydroxy calcitriol, and that's your active vitamin D. And the high ACE enzyme levels, that's going to make a lot of angiotensin too. So patient's going to have high blood pressure, typically along with their tachypnea. And that's a bad combination. Most patients show hilar or mediastinal nodal enlargement only. So if you do see this, then your differential is narrowed not significantly due to the node involvement, but if the node involvement is the only thing you see, then you're like, oh man, okay, granulomas, what can cause a granuloma, right? Because, well, if it starts off as a peripheral disease and moves towards the lymph nodes, you're gonna see the periphery of the lungs just light up, right? You're gonna see a reticular or a nodular pattern, but if it's only the lymph nodes, you're thinking it's gotta be something infectious or autoimmune that has only those lymph nodes involved. We hit these patients with a fat dose of steroids, and it tends to work pretty well, but depending on where in what tissues get involved, there can be some pretty bad symptoms resulting from the mass effects of these sarcoidoses, those sarcomatous granulomas. Let's talk about hypersensitivity pneumonitis, also called extrinsic allergic alveolitis. So you're exposed to an antigen, which is an antibody generator, and you make antibody, and then the problem is going to be that the antibody starts sticking to your own cells, which is going to cause your immune system to roll through and those cells that the antigen sticks to. And the most common variants of this are farmer's lung and pigeon breeder's lung. I really tried to not laugh at that, but yeah. So here's a nice table that looks to me like 5 answers to a test question, right? And here's your antigens. And in the case of farmer's lung, you need to understand that actinomyces is a soil-dwelling bacteria. And we know this because you've seen the sketch sheet for Actinomyces israeli, right? And well, where do you find that? Soil, right? And then nocardia, well, that's its cousin, okay? Because that's also a branched filamentous gram-positive. And so where do you find that? Soil. So what do farmers do? They till the soil every day and they plant, right? And they're walking in the field doing their farmer stuff. And so when they're riding on their big green tractor, they're blowing up actinomyces all in the air. And if they run over a nest of actinomyces, let's say, maybe it just goes straight into their lungs, and then maybe it causes a hypersensitivity. Hey, it could happen to you. So Mycobacterium avium, intracellular, hot tub lung, MAI, that's typically affects the immunocompromised. So it's going to be old people, the immunosuppressed, lots of long-term therapies for different conditions involve immunosuppression. It can be transplant patients, and it can also be HIV/AIDS patients. Specifically AIDS. I think that's an AIDS-defining illness, actually, because it only really pops up when CD4 is less than 50. Then there's IgA from pigeon droppings, and that's pigeon breeder's disease, and I will say no more about that. And then there's diphenylmethane diisocyanate, which shout out Wikipedia, because that's how I'm going to learn what that is. It's a hypersensitivity. It's an autoimmunity. So, of course, you have high IgG because IgG is your go-to antibody, right? There's 4 types of IgG. There's only 1 or 2 types of all the other immunoglobulins. So IgG is your circulatory first-line antibody. So it's going to be elevated here. IgE is going to be normal because it's not an allergy particularly. It's going to be more of a immune complex or cell-mediated hypersensitivity, and you would see IgE if it were a type 1, okay? Pathology, well, you start to see neutrophils and fibrinous exudates within the lung because this is a hypersensitivity targeting alveoli and pneumocytes and fibroblasts within the lung. And then this can progress into granulomas if it's a type 4, and if it's a type 3, it'll stay limited to the vascular endothelium, but it'll really mess that up. And in both cases, the inflammation leads to fibrosis because when the inflammation calms down, you get TGF-beta. Once more, you get all this fibrosis, oxygen doesn't want to move through the fibrosis, so you get hypoxemic, you get this VQ defect that just keeps going down as ventilation goes down, so your total lung volumes go down, 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 down over time. This leads to pulmonary hypertension as you try to maintain the same oxygen perfusion by keeping up Q, right, to maximize flow. And then that leads into right heart failure as everything backs up and you just go downhill. Acute hypersensitivity pneumonitis can be due to a brief exposure. It's very quickly after exposure and their general symptoms, and they typically resolve rapidly. Quick on, quick off. Now, subacute is pretty long with a prolonged exposure, and symptoms are often very prolonged over weeks or months. Then chronic hypersensitivity pneumonitis is going to be due to a little bit of exposure on a constant, continuous basis. Lung biopsy frequently has an important role in separating hypersensitivity pneumonitis from interstitial pulmonary fibrosis. And how are they going to look differently? Granulomas, bingo, or type 3. Immunostain it. Stain it for IgG. If it's a vasculitis, you drop some IgG stain on a lung tissue and it'll light up, right? So that's your differential. You might see a lymphocytosis in the blood. Not too specific, but CD8 T cells in a bronchoalveolar lavage, that really supports it, because when do you see CD8 T cells? Well, those are your Th1 T cells, okay, and those are your Th1 cells that just, they just walk up to another cell and just knife it, okay? They're the dudes in COD with like the 15 kill streaks every match with like akimbo pistols and a riot shield. So you find those whenever you do a lavage of the lungs, and a lavage is basically when you wash out the lungs with water. You put someone to sleep, you put a bunch of fluid in their lungs, and then you get them to spit it all up, or you vacuum it out. And then you look at the cell content of that lavage. And we're about to talk about lavage even farther with pulmonary alveolar proteinosis, because you have to lavage those patients too, except it's going to be therapeutic in that case. And then finally, for hypersensitivity pneumonitis, just stop doing whatever caused your pneumonitis, okay? And that's if you're a pigeon breeder especially. Pulmonary alveolar proteinosis, because it is a restrictive lung disease, your compliance goes down, your elasticity goes up. So there's a higher resting pressure in the lungs due to that high elasticity. So air doesn't want to move into that high pressure zone, so the volume in the lungs drops. So your FVC goes down, but because air wants to move out of your lungs, your FEV1 goes down even more, so that ratio is higher. And this leads to a hypoxemia because oxygen doesn't want to diffuse through collagen. Now, how does this all get started? In the case of pulmonary alveolar proteinosis, it's because you make too much surfactant, so your lungs are really boggy and fluid filled. Remember that, well, what's the disease where you're not making enough surfactant? Infant respiratory distress syndrome. So if you make too much surfactant, that can also lead to bad things. And you're making too much surfactant either because you're overproducing it or you're not clearing it out. And your macrophages are responsible for clearing out. A lot of genetics involved here. the SFTP, A, B, C, and Ds. Those are your overproduction genes, your surfactant protein genes, and then granulocyte macrophage CSF. If there's a loss of function mutation in that gene, you can inherit it or acquire it, and then that's going to be an underclearance of surfactant because your macrophages have to go around. They're like a Roomba, right, on the surface of your alveoli, and then your macrophages are scooping up leftover surfactant that you don't need, and they're making sure it gets out of there. So if they don't do that, too much surfactant. And then if you overproduce it, too much surfactant. So what sort of pathology do we see in this setting? If there's a layer of fluid lining the surfaces of your alveoli, I shouldn't have to explain to you why it's going to be a little bit harder for oxygen to diffuse into your bloodstream. It's just because it has to travel a farther distance to get into the bloodstream. So it's harder to get air into the lungs because that fluid's also going to, that fluid's a mass. And then the mass is going to add to the pressure into the lungs. So that's also why it's harder to get air into the lungs, which is going to participate in sending ventilation downhill, contributing to the VQ defect. The lungs are going to be swollen and heavy. And the precipitate's going to be PAS positive. What else have we seen in this lecture that is going to be PAS positive? Silicosis, silica crystals, those stain PAS positive, and they're spherical as opposed to asbestos, which is linear and segmented. Immunohistochemistry reveals a ton of surfactant. Let's talk quickly about 3 reasons why you might have a surfactant overabundance. The first is going to be congenital, and there'll be mutations in these 2 classes of genes. As we've said, if you have a surfactant protein mutation, specifically protein B and protein C, you're going to overproduce surfactant when there's a gain of function type of mutation. And then if you have a mutation in colony stimulating factor 2 receptor A or B proteins genes, then you're going to have macrophages that are your macrophages are vacuum cleaners, and then if these genes don't work, your macrophages don't vacuum as much, so they don't get the surfactant out of there. Please recognize that all of these genes are inherited autosomally recessive except for surfactant protein C, which is autosomally dominant inherited whenever there's this bad mutation. You need granulocyte macrophage colony stimulating factor in your bone marrow to induce the differentiation of certain pathways in the myeloid lineage. And then you also need it to get your tissue resident macrophage stem cells to differentiate into macrophages. So you don't have GM-CSF, your macrophages don't grow up. They stay in their parents' basement until they're 40. Then you can also get a primary, what is this thing even called? I just know it as a surfactant. Pulmonary alveolar proteinosis, okay? Then you can get a primary pulmonary alveolar proteinosis, which is an autoimmunity targeting granulocyte macrophage colony stimulating factor, granulocyte myeloid, whatever it's called. Then finally, you can get a secondary alveolar proteinosis following particular infections or particular leukemias. And I think that's kind of misleading because my understanding is that these things are also going to lead to an autoimmunity. So I suppose that it's going to be primary when we just don't know why there is an autoimmunity. That's it. And then the secondary is like, well, we know why there is an autoimmunity. So there's really 2 causes. There's inherited and autoimmune or acquired. And then within that category of autoimmune acquired proteinosis, we can say, well, we know why it's there or we don't know why it's there. And so causes that we know cause this thing are going to include blood cancers, nocardia, branched filamentous weakly gram-positive bacteria that stains acid fast and is found in soil. I hope you didn't get that wrong last exam. Mycobacteria, mycotic acids in the cell wall, mycolic, maybe with an L. TB is one such bacteria. Obligate aerobes don't stain any gram. They stain with acid. I'm sorry, they stain with, they stain acid fast with the Zeal-Nielsen stain. That's what it's called. and you grow them on Lowenstein ginseng agar. I think you typically get that from respiratory droplets. You got to be exposed to an infected patient, although you can get that from soil as well, I think. Cytomegalovirus typically only affects the immunocompromised, and it'll be a quick infection, where CMV is really of worries in the neonate. Histoplasma and Cryptococcus, those are dimorphic fungi, meaning they have both a mold and a yeast form, and so they're also going to cause some nodules and some hypersensitivities in a lot of different places in the body. And the primary histo and crypto infections are going to present in the lungs. Actually, Cryptococcus isn't dimorphic, that's blasto. That's dimorphic. Cryptococcus affects the immunocompromised. How do these things present? VQ defects. So dyspnea upon exertion, and then you cough up a lot of fluid. Why? Because you're overproducing surfactant, so there's just fluid in your lungs, period. And how we treat this is with MABs, I believe. Actually, no, not with MABs. We just give them granulocyte macrophage colony stimulating factor, I assume. And then you also have to lavage the lungs and wash them out periodically in order to get rid of all the proteinaceous kind of gelatin lining the insides of the alveoli. And I picture a lavage, and I think about like washing out a cup after you make a protein shake, because you know the protein's still stuck to the cup. Well, same visual applies to the lungs here when you're overproducing surfactant. And then imaging, you see diffuse ground glass opacification. What does that mean? That means there's fluid in the alveoli, okay? And then diffuse symmetrical alveolar infiltrates in a bat wing configuration. That's not too characteristic, and you'll have a lot more to go off in the question stem than just that. So overall, understanding that it's a restrictive lung disease is easy, and good luck with whatever they decide to ask us.